So Alan's been doing an enormous amount of work on an enormous amount of things. One of the main things he's been working on is his AI and digital healthcare technologies framework for the NHS. So AI competency within the NHS, amongst other things. Alan's the project lead on a unit I teach on. So yeah, well, without further ado, I'm going to hand over to Alan, who's going to be talking about the AI and digital healthcare technologies capability framework.
Thank you very much, Cam. It's always good to have a good intro. So hello everyone, and nice to see you this morning, and those people online as well. So for those of you that don't know me, I'm Alan Davies. I'm a senior lecturer in health data science at the university and the program director for our new clinical data science program that John mentioned that he also runs a unit on. Yeah, my background is a bit eclectic for those of you that don't know me. So I started, as John said, in computer science. So that's where my PhD is in computer science. I've worked in industry as well as a software engineer and an app developer, also for the university as a research software engineer before becoming a lecturer. I also used to work a long time back as a registered nurse in interventional cardiology. So working on things like routine and emergency angiograms, angioplasties, pacemakers, that kind of thing. So I've got a bit of a background in health and technology, and it's coming quite useful in this kind of eclectic career that I have so far. So this morning, I'm just going to talk to you a little bit about this AI and digital healthcare technologies framework that we developed here at the university for Health Education England, as it was then, which is now NHS England. So I realised that the audience might be a bit mixed. So to try and make sure that there's sort of something in it for everybody, I'm going to touch on a few different things throughout the talk. So I'm going to talk about the need for the framework. So why did we make this in the first place? Some of our related work, and that will become clear how that's connected as well. Methodologies for people that might be interested in designing such frameworks. How we apply the framework. So some of you might want to know, how do we use something like this? Also, how do we keep these things relevant? How do we, once we've made them, what do we do with them then? And also looking at kind of the future and how we might be able to come up with things like digital representations of these frameworks that hopefully will be interoperable and people can actually use them in a cleverer way rather than them just being on a website or a PDF document that people refer to. So that's the main overview of kind of what I'm going to talk about this morning. So just a little bit of background to sort of set the scene. As I'm sure most of you know, there's been quite a lot of recent sort of work in the NHS looking at how we can meet some of the challenges of the 21st century healthcare. So we've got lots of older people now, we've got lots more comorbidities, we've got it's getting more complex, we've got problems with staffing as well, all sorts of problems with the NHS at the moment. And some of the solutions, not to everything, but to some of these problems, have been identified as basically using technology. So things like digital transformation, can we leverage this to help us address some of these problems? So there's been some recent high-profile reports and reviews, the Topple Review, for example, the NHS Long-Term Plan, which very much talk about the need for digital transformation and leveraging those opportunities to meet the healthcare needs. The one in the middle, the Goldacre Review, is more around using data for research. It's kind of, can we leverage a lot of the data that's generated in the NHS to improve care and to carry out research? So these things are kind of connected. There's been a lot of talk about this, but one of the big issues here is not just the technology, but do the people actually have the skills and capabilities to use the technology? So that's the sort of the angle at which we're coming at this. So digital transformation really just refers to the way technology changes an industry, in this case health service, and it influences the way people work. And it's actually a combination of quite a few different things. It's the technology itself, so things like digital enablers, and this is a non-exhaustive list, but it includes things like AI, the cloud, big data, chatbots, mobile apps, genomics, Internet of Things, sensors, teleconsultation, telemedicine, all that kind of stuff. So there's loads of these different bits of technology or digital enablers that we can use for digital transformation. There's also a need for infrastructure, and people sometimes ask me, what do you mean? Do you mean the buildings? And I mean, yes, I do also mean the buildings as well as the digital infrastructure, because you can't have, robotic surgery if you've got crumbling buildings and you haven't got enough plug sockets to plug things in. So you do actually also need to make sure you've got the basic infrastructure, but also the digital infrastructure. Have you got the Wi-Fi coverage? Have you got the technology that you need? Which kind of links to the level of digital maturity that an institution might have. So at the lower level of digital maturity, you might have eclectic thing. You might just have an electronic health record system. moving on from that, you might have different bits of technology that address different problems, but at the higher end of digital maturity, you'll have a proper strategy for your digital transformation. You'll have an ecosystem that's connected, so the different apps and services all work together and feed into one another. They're not just piecemeal solutions to specific problems, but they're unconnected. So ideally, you want to move from that sort of, eclectic mix of technology through to a proper strategy and a proper plan, and making sure that you've got the infrastructure, both physically and digitally, to manage that. But as I pointed out here, the main focus of this talk is really around the workforce development. So how do we upskill the workforce with the competencies and capabilities that they need to be able to use these technologies effectively to meet that need? So it's all these things have to come together. We need the technology, we need the infrastructure, we need the buy-in from leaders and management to kind of push the change forwards, to manage the change. And then we need obviously the skill from the people using the technology as well. So that's definitely the focus of what we've done the work on here is how do we upskill the workforce. So that lots of people look at things like job analysis, competency modelling, and these are quite popular ways for people to look at this. And you can use things like competence models for things like training, developing people's careers, recruitment. So you can use it for writing job specs, that kind of thing. You can use it for performance management as well, making sure people are meeting a certain level of criteria. You can use it for developing training or educational materials, and sometimes also for accreditation and professional membership. So if you've ever worked clinically, so when I was doing nursing, for example, you'd have certain competencies you had to meet to be registered as a nurse. So and you have to keep those competencies up to date. So if I couldn't catheterize somebody or do a dressing or whatever, then I had to demonstrate competency in those things to be able to register as a nurse. So some of these competencies can be very formal, like you have to meet them to work, and others can be more optional things that you kind of add on top. So I talk about capabilities and competencies. So I just wanted to take a second to kind of talk about what I mean by this, because they are different, and often in the literature you might see them used interchangeably. They'll say competencies, capabilities, but there is a difference between the two. Capabilities are a slightly lower level than a competency. So it's really a kind of starting point where you've got the basic requirements, the skills, behaviours, attitudes or ability, whereas a competency is a sort of a higher level of meeting a level of performance, if you like. So the way that I think about this is I might be capable of riding a bike. I can get up, I can't, but if I was, I could get on the bike and I could pedal it around. But that's different to being competent at sort of cycling around an urban city, knowing the highway code and doing it to a certain standard. So there's lots of arguments in the literature about the difference and where the line is drawn. I'm not going to get into that here, but this is the kind of working definition that we're using for this talk. So often with capabilities, you can develop them into competence, and that's also where people might move from generic to specialist kind of roles as well. So there's also, you might be aware of digital literacy. So there's organisations like JISC, and they're very much focused around kind of bridging the gap with essential foundational digital skills. So as a computer scientist, I'd look at these as being quite basic or foundational. So it's more like, can you switch your machine on? Can you send an email? Can you download an app? Can you, these kind of what I would consider basic kind of IT skills. But this is definitely the foundation level of which everything else is built, because if you can't do some of these basic things, you're definitely not going to be able to manage to do some of these more advanced capabilities and competencies. So we do have organisations like JISC. It's not focused specifically on health, it's just general digital literacy, although different frameworks and things have been built on top of this initial framework. So the NHS through Health Education England did come up with a framework which is called a Health and Care Digital Capabilities Framework, and it was developed by Health Education England, and it's split into these kind of 6 main domains of capability around communication, collaboration, teaching, learning, development, information, data, creation, innovation and research, and technical proficiency. And this is very much based on those foundational capabilities. So it's still quite a kind of low-level framework in terms of its we're not talking about advanced digital skills here, we're not talking about AI, we're not talking about robotics, we're talking about more of the fundamental digital skills that you'd need as anyone working in a modern healthcare service to do. Can you maintain your software, can you update things, can you be safe online, that kind of thing? Can you basically protect against cyber fraud and crime by not doing things that, obviously maybe you shouldn't do? So again, very foundational level, very important. When I say foundational, I don't mean it's not important, of course it is. It's just that it's a kind of lower standard in terms of technical complexity, but of course we need that as the foundation. And obviously, we've got places like the Royal College of Nursing that use their digital skills, all based around these kind of documents and all based on JISC here. So that's how that's kind of been formed. There's also lots of other professional frameworks that exist out there as well. You might have come across lots of them. There's the Federation of Informatics Professionals, FedIP. There's HitComp, which was an international framework that was designed as part of a Horizon 2020 project that looks at health information technologies competencies. There's also ones specific to different professions. So you've got ones like Tiger, which is an international framework for nurses. There's different ones for bioinformaticians as well. The World Health Organization have published one. So there's lots of different frameworks out there. Some of them are international, some of them are national, some of them are focused on specific disciplines or professions like nurses, bioinformaticians, or surgeons. So there's lots and lots of these frameworks out there, basically. So the challenges we had is we're putting another framework out into this already crowded space. And what we wanted to do is, or what we were commissioned to do, was to create a framework that sits between those foundational digital literacy frameworks and some of these more advanced specific frameworks for people like informaticians and data scientists, statisticians, that kind of thing. And it also needed to cover some more of these advanced areas like AI, like robotics, that aren't covered in those foundational documents. The other problem is we needed to make it work for a large swath of the healthcare workforce. And as you can see, we've got about 1.4 million employees in the NHS. Not all of and that's all sorts of things from estates through to bedside. So there's a lot of people with lots of different backgrounds that need to start to develop those digital capabilities further. So it's actually very difficult to make a framework that's aimed at such a large amount of people, because it'd be much easier to make a framework just for nurses or just for doctors or just for surgeons. So trying to make something that works for everyone is really challenging. And also, as I mentioned earlier, a lot of these people, they have to meet certain competency frameworks for their employment or their professional registration, and we're asking them now another thing. So if you're a doctor or a nurse and you've got all these clinical competencies to keep on top of, and now we come along and say, oh, well, we've got all these digital ones as well, that starts to become perhaps quite burdensome for people to manage. So you've got to be careful how we introduce this. The NHS is under a lot of strain already. There's a lot of burnout. There's a lot of people leaving. So we don't want to be overly kind of top down with how we enforce these kind of things and sort of force people to do them, because it's going to be challenging for those people. So I'm going to deviate slightly and talk about some of our previous work that is related, and you'll see how it connects in a minute. So we were commissioned by the Faculty of Clinical Informatics at the time, the FCI, to produce a core competency framework for clinical informaticians. So this was a small team at the university that was led by Professor George Moulton, with myself and Julia Mueller. And so there's only 3 of us on this project. It's a small project. And usually with these kind of frameworks, you don't get a lot of money and you don't get a lot of time. So it's quite challenging to come up with something meaningful in that amount of time. But we applied a mixed methods approach to this. So we had some previous work that was done by the faculty, which you can see here. So they've done a couple of reports on kind of what is a clinical informatician. They've kind of scoped the kind of space. They interviewed their members, and then we fed that information into our phase 1, where we looked at actually, creating an evidence base for these capabilities. So we did a systematic literature review. We also looked at some job postings, and I'll talk about this in a little bit more detail. And once we'd done that, we came up with the first draft of this framework. Then we went and had some expert interviews. So we sat down and interviewed 15 experts, showed them the framework and got their feedback. Taking their comments on board, we made changes yet again, and then we sent it out via a digital survey where 87 people filled that in, and then we changed it again. So then we came up with that final version of that framework, which had 6 domains, 36 subdomains, and 111 individual competency statements. So we kind of did that in stages to kind of form it. So the first stage was that kind of what does the evidence show? So we carried out a systematic review. We actually had over 10,000 hits here. When we filtered them, we had about just over 8,000 papers to screen, title and abstracts. So that took a long time, as you can imagine. And we had 82 full text papers, and we looked at all kinds of informatics disciplines, so nursing informatics, bioinformatics, pharmacy informatics, all of those different disciplines. And we extracted from those what were the main kind of skills, competencies, capabilities, and what levels were they done at, basically. We also looked job postings as well, so we didn't have time to do, so we'd done talk about interviews later, but we didn't have time to sort of do this in a kind of more of a qualitative way. So we actually applied some natural language processing to this task, basically. So we took 50 job postings that were online, we split them into, we basically made a file for each of these things. So one file for duties and responsibilities, one for abilities, one for experience and knowledge, one for qualifications, and one for skills. The D and E means desired and desirable and essential, that's it. So we had a version each. So one version was for the desired skills and one was for the essential skills. And basically we cut and pasted the bits of the job postings into these files, and then we ran some NLP techniques over them. So we looked at things like the word frequency, and we also looked at things like bi and trigram analysis. So that's kind of how different words appear together in a sequence. So bigrams, 2 words together, trigrams, 3 words together, and so on. And you can see an example of a network graph looking at bigrams. So here you can see, for example, clinical governance, clinical and governance policy, health policy, clinical practice, right project documentation. So you can kind of start to see how these things fit together. So it's a little bit more useful than just word frequencies. You start to show how the words occur together. And obviously you've already grouped them into things like skills, qualifications, so we know what the kind of topics are. There's no point doing topic modeling, we already know what the topics are. So we put them into there, and we're able to also get some additional gaps from doing this. So we've got what the literature says in the published literature. Now we've got some of the gaps that we found through job postings, which are obviously more up to date than the literature and might have slightly different angle, and then we're able to combine that with our interviews and then finally the survey. So going back to the AI and digital capability framework, how's that relevant? Well, when the Health Education England came out with their tender for this framework, they actually cited the FCI framework as an example of the sort of thing that they were trying to achieve. So we thought, well, as we have made that framework, we may as well bid for this other framework, and obviously we got the bid because our previous work was related to that. So we applied a similar mixed methods approach to this framework with a few differences. So we did also carry out a systematic review of the literature, but for us this was actually done by Health Education England and their knowledge and library specialists. It saved us a lot of effort in this case because they did that bit of the work for us. And we also then carried out 3 workshops instead of kind of doing interviews. And then we also followed that with a digital survey. So again, we kind of produced this thing in stages. And from the literature review, we were able to come up with what we called a concept map. So basically, we just took all the different things that we saw in the literature and we grouped them together in kind of like a hierarchy. And it was very roughly done. It's not perfect, but it just gives people an idea, a starting point really, with which we might work with. It's quite difficult when you turn up to something and there's nothing tangible. So we thought we'll give people this as a kind of foundation from which they can use for ideation. So we weren't expecting them to stick to it, but we came up with, I don't know if you can see it very well here, but it had things like cyber and data security, ethical and legal, data, human factors, AI obviously, and that's split into things like natural language processing, machine learning, decision support, and then we have digital healthcare more broadly, which are things like augmented reality, virtual reality, telemedicine, robotics. So that was our kind of our rough grouping for ideation. So we also looked at, when we did the review, we looked at policy documents, existing frameworks, reports, and all that was fed together to produce that concept map for the workshops. And the workshops, we had 3 different workshops, which we repeated, the same workshop with 3 different groups. The first group were early career digital leaders, so people like the Topol Fellows, industry representatives, so we had Bupa, Barclays, people like that in there, and then educators and subject matter experts, so academics and people involved in that. We did this online because it was kind of around the kind of COVID time, and some of the people in this room were facilitators in this, so they actually helped to facilitate the breakout rooms. So we basically use Miro. If you're not familiar with Miro, it's kind of like an online digital board that you can see here. You can make post-it notes and that kind of thing. And you can put people in breakout rooms and they can discuss things. So that's what we did. And we used something called the nominal group technique, which is quite useful as a kind of consensus method. So you might have heard of things like the Delphi method, that's probably more popular, but the nominal group technique is very good when you want to avoid things like groupthink, where sometimes you've got dominant people or senior people that might sort of take over, and junior people might kind of be quiet and think, well, I don't want to say anything because they're senior. So this helps to remove that barrier, and it also helps when people don't know each other very well as well. So it helps to kind of get you to work together quite effectively. Essentially, it has these phases. So it's got a nominal phase, an item generation phase, clarification and discussion phase, and a voting phase. So the nominal phase is normally private consideration of the information. And to do this, we sent them the concept map before the workshop. So that gave them an opportunity offline to think about the concept map, jot any ideas down, have a little think about it in their own time. And then during the workshop, we did the item generation. That's where you share individual ideas in rounds. So what we did is we prompted ideas to share their ideas one by one. So they weren't allowed to interrupt. One by one, they shared their ideas. These ideas were jotted down on a digital post-it note by the facilitator and put on the board. And we went round and round in rounds until we ran out of ideas, basically. Then the clarification and discussion phase is where people then have the opportunity to ask questions. So you go back through all the post-it notes one by one, read them out, and then people have the opportunity to question that, clarify things, maybe combine things, that kind of thing. And then finally, we had a voting and ranking stage, and we got people to position the post-it notes on the board, basically from what they thought were the least to most important and the least to most complex. So they'd kind of physically move their post-it notes around in that section. So we kind of voted on essentially which they thought were the most important of these capabilities. And they didn't have to kind of come up with the actual capability statements, just the ideas behind it, what should be included, essentially. So that's kind of the methodology that we use to come up with the framework. The framework itself, this is kind of what it looks like. So we definitely have this foundation of digital literacy. So it's really important that people already are capable of doing the things, say, in the first framework before they look at this one. But then also another interesting thing that we found that's obvious when you think about it is a lot of these more advanced technologies like wearables, AI, robotics, they're all built on data. So if people don't have that foundational knowledge of data literacy, then you're not going to be able to use effectively these other more advanced technologies. So you're not going to have good machine learning or AI or robotics if you're feeding rubbish in to those models. So being able to understand data and data literacy kind of form the next level of that foundation. And then on top of that, we've got our specific digital enablers, our apps, technologies, and so on, and then more advanced concepts of sort of artificial intelligence and robotics and AI at the top there. Obviously, throughout the whole thing, we've got things like human factors, people, culture, processes, ethics, and then also we've got different levels of digital maturity as well, where different organizations will be achieving bits of this at different points, essentially. So data is definitely the kind of thing that powers the more advanced areas in the framework. So we, again, to deal with the issue of we're trying to make a framework for like hundreds of different job roles, which is anything, sometimes people naively think, oh, it's doctors and nurses, but actually if you think about the people that work in the NHS, there are orthotists, there are podiatrists, there are technologists, there are technicians, there are scientists, there are all sorts of people, literally many roles. And I think if we tried to make some complex framework with all of the different roles, it would just be a bit of a mess. So what we decided to do is, instead of doing that, we came up with some archetypes instead. So we've got shapers, drivers, creators, embedders, and users. And the idea is that the individuals or their managers will self-identify which of these archetypes they're actually in. So you can kind of, and the other thing is that can change as well. So you might be more than one of these things, or you might alternate between them at different times. So if you're a nurse who works on the ward, you might be a user of this technology, but you might also work in an informatics team or in some kind of on a research team or whatever, digital transformation project. And in that case, you might actually be embedding the technology or even creating the technology. So you might flip between them at different stages and so on. So this kind of openness lets you self-identify with which archetype you think you fit with, and then identify the capability statements that you think best fit your, what you're trying to do. So hopefully that was a kind of rationale as to kind of why we did that. And it came from originally a report from the Ministry of Defence, actually, that used something similar. So that's where we got the concept from originally. We also mapped this against the Bloom's digital taxonomy. So if you're familiar with Bloom's taxonomy, this is the digital version of that. And Bloom's basically, it moves from what we call lower order thinking skills. So things like just remembering something. So can you memorize and recall things? All the way up to what we call higher order thinking skills. So we get into things like analysing, evaluating, and creating. So each of the statements moves from these lower order to higher order skills on the taxonomy as well. So from basic awareness and remembering things through to actually being able to create and evaluate at the higher end, basically. And this is the main domains of the framework. So we've got digital implementation. So how do you actually get that stuff into healthcare? What are the, how do we evaluate and implement this stuff? Digital health for patients and the public. So this is really around, and that was another challenge because it wasn't just an AI framework, it's an AI and digital technology. So you've got to think about wearables, apps, telemedicine. So that's really what fits into this category here. So it's kind of people that might be prescribing or using that technology through to people developing that technology. Then we've got ethical, legal and regulatory considerations, human factors and health data management, and then artificial intelligence. And these break down into further subdomains. So you can see, for example, in AI, we've got machine learning, we've got evaluating AI systems, using and implementing them, we've got robotics, and so on. So you can see kind of these break down into different sort of subsections or subdomains. So that's kind of how it's loosely grouped. So if you go into one of these domains and one of the subdomains, you actually get to the capability statements. It looks a bit like this. So this is from domain 6, artificial intelligence. So you've got a bit of a description about what it is, and then you've got these 4 levels, and these levels come from the original HEE framework. They wanted it to be compatible with that one, so that's why we've got these 4 kind of fairly arbitrary levels, but we've used them as kind of levels of complexity or difficulty, if that makes sense. So level 4 is going to be harder than level 3 and so on. So level 1 is going to be the easiest one. These letters, these relate to the archetypes. So this one's shapers, drivers, creators, and users. So that's everybody. So we're saying level 1, for example, in this case, I understand that AI is an umbrella term used to define digital technologies capable of performing tasks commonly thought to require human intelligence. So this one is I'm aware of, basically. And then move through to level 4, where you actually often delivering, evaluating these kind of technologies. So someone that might be working on a project, actually implementing the technology, versus someone who just needs to know what it is. So they move through in that order. So that's the framework and kind of how we made the framework. What can you do with this framework once it's been made? So again, you can use it for things like designing courses, curricular workshops, career development as well. You might use it to see where the gaps are in your learning. You might use it to see where, things that you might not know so much about. So identification of your learning needs. You might use it to develop training and educational materials. You might also use it for accreditation or professional membership as well for different groups. So one example of where we've applied it is our clinical data science program. So this is a blended learning program that runs 4 core units. Each one runs for 9 weeks. We co-designed this with the workforce, basically, and it's designed for busy clinical people, so people that work in the NHS, and it's funded by NHS Health Education England. And essentially, it's got 4 core units: clinical data engineering, which is all around data wrangling, data quality, that kind of thing, databases, architecture, data lakes, all that sort of stuff, and then and data quality. And then once you've got your data in the right format, the math, stats, and machine learning unit, which John leads on, is all around kind of applying those analytical techniques, so machine learning, NLP, statistics. And then human factors and digital transformation, led by Davies and Helen Hume, looks at co-design, implementation, evaluation, and data visualization and communication, which myself and Fran over there lead on, is all around kind of, how do we visualize this complex data? How do we describe that to different users? Is it to clinical people and also to lay people? So this program, and also we recently ran a workshop with colleagues at Melbourne University around machine learning. We used in both cases, we used the framework to map onto the learning objectives. So we used that to help us come up with what are the learning objectives that we need to meet in order to design the course. So that's one example of the kind of thing you can do with it. You can use it to help generate individual learning outcomes for a particular course or a workshop, underpinning it and linking it to frameworks. So as I mentioned before, there's quite a lot of issues with kind of maintaining relevance with these things. There's an organisation called AFA, which is the Association for Healthcare Analytics, I think. So these are all the people in the NHS that do health analytics, so they're not data scientists. For me, the difference in someone that does analytics is they tend to work with routine data, so routinely collected data, and then analyse that data. So they might be looking at bed stays or how many people came into A&E that month, whereas a data scientist is going to combine data from different sources and look for new questions to ask and new questions to answer. But there's definitely a spectrum between kind of analysts and data scientists, and you can see just looking in their report on frameworks, just for service analysts, you can see there's a huge list of frameworks here that just for this one group of people. So there's a lot of frameworks out there. And I think part of the problem for users of frameworks is knowing A, what's out there, B, what's relevant to me, which framework should I be looking at, how do I find them, and once I found them, how do I look through them, because they're all pretty hefty, bulky things, you know, hundreds of statements. How do I find out what's useful to me, what's relevant to me? So we definitely need to make these things more joined up. We definitely need to avoid, where we can, repeating and remaking these frameworks over and over again. So if we've got, you know, I think if we keep getting commissioned to make new frameworks, we should be a bit cautious about that and maybe look at what's out there already. Do we really need another framework? What value is it adding? And also, if we do make it, people really need to be able to access the framework, search it easily if we want people to be able to use them. They also need to know where to find them. And one of the things you can do to keep them relevant as well is maybe setting up a working group. So once you've made your framework, set up a working group, a group of people that meet semi-regularly to discuss the framework and keep it up to date. You know, keep making sure that it reflects the latest capabilities, the latest competencies for those things. Another thing you can do when you design them is try to future-proof them a little bit as well. So I would avoid saying, for example, I'm making this off the top of my head, but must be competent with Python, because we don't know in 5 years' time, is Python going to be the main thing? It could be Julia or another language you've not heard of yet. So maybe just say with a modern data science programming language, and then that way that can be whichever's in vogue at the time. So sometimes when you're designing them, you can kind of build in some flexibility there to keep them up to date. And working groups are really good to kind of keep that focus on them and stop them from going kind of falling by the wayside. We can also integrate them into tools. So HEE, NHS England is now, has a digital skills assessment tool, and they were planning to put that framework into that tool. So the idea is people can use the tool to look at kind of where they're at with their digital skills, and it will suggest to them different courses and things that they might want to do. And again, integrating things like the framework into those tools could be quite useful. We were also commissioned to write a paper for the International Journal of Medical, one of those special editions. So we wrote about our framework with the FCI, and we talked in that framework about how we keep them relevant. And we came up with a bunch, I'm not going to read them all, don't worry, came up with a bunch of recommendations for keeping these things kind of, you know, how do we keep them relevant once we've made them? So just to pull out a couple of them, really it was you know, targeting the group that we're aiming it for, avoiding repeating these things if we don't need to, you know, replicating them, making sure we build them on an evidence base, so using some sort of evidence-based process, preferably an iterative process that involves different aspects to really capture what you're trying to include. Again, co-design is really important as well, making sure you're including the people that are going to use these frameworks in the design of the frameworks, reviewing and updating them periodically. Consider presenting it in a form that's easy to reuse them. And they're increasing, there's just so many of them out there basically that we need to start thinking about how we're going to join these things up a little bit more basically, and avoid that kind of confusion for the people that are using them, which led us to recommend considering digital formats for these frameworks, because we talk a lot about technology and digital this, and then it ends up being a PDF document or a list on a website, which isn't very technically advanced. So can we have better technically advanced representations of these frameworks? So another thing we suggested in there was, you know, can we represent them in different ways as well? So can we represent this knowledge in ways that might be easier to work with? And one suggestion was maybe using a graph database to do that. So this is an example of a graph database using something called Neo4j, which is probably one of the standards for graph databases. So it's essentially a directed property graph. So these circles are what they call nodes, or vertices, and it has edges or these lines, and they represent relationships. So this is a made-up example, but you can see we have Sean Jones was treated, so he's a doctor, treated Jane Smith, who was diagnosed with lung cancer. Jane Smith was admitted to this hospital, which is located in London, Sean Jones works at this hospital. You can start to build up a connection between these entities. You can also label them with key value pairs. So you can have departments, phone numbers, rooms, and this data can vary depending on the node in question. So you can store the data that's relevant to those nodes. You can even label the relationships as well. So you can put extra labels on those as well. So these kind of graph databases are very good when the structure of the data is as important as the data itself. So we thought, what would happen if we represented this framework, for example, in a graphical form? Would that make it easier to use? So we had an MSc project for the MSc in Health Data Science, and one of our students, Yao Wu, who was supervised by myself and John, came up with this graph database version of the framework, but you can see it's still pretty complicated on here. So we actually tested it out with some people that might use such a framework, and they found that it was still very complicated to kind of make sense of using it in this format. So it was a nice idea, can we sort of represent it in this way? Would that make it easier to sort of visually see it and search it and so on? But actually it's still quite a complex representation. But the idea was that we'd have that kind of data model in the background, and then we'd have something like a website that you could filter on it as well. So you can choose your domains, subdomains, and so on, your levels, your archetypes, and it will filter that, and it will give you back the capabilities that it identifies. So this is the kind of thing we're looking to create, basically, is can we have some kind of like website, something like that allows users to come in and like search for what might be relevant to them, basically. So they can search based on level or archetype, or if they know what particular domain or subdomain, and then it will spit back the capability statements, and then ideally they can export that in a number of different ways to use that however they want to use it for designing a course or whatever it is that they might be looking to do. So we've got another couple of projects coming up that are related to this this year. So one of them is creating an API for this framework. So an API is an application programming interface. So it's basically you can write bits of code to query the data and it pulls stuff back. So this is a way you could integrate that into another tool. So if you were going to write another tool or develop another tool, you can query the framework using code, and then it will send you the data back for you to use it in your tool, basically. And that way, if we maintain the framework in a central place, you don't end up with these kind of versioning problems of I've got this PDF version 1.1, version 1.2, are we using? So we've got the latest version always in one place, and then you link to it with your tools that you're developing programmatically. So that's really a way an expert might use the framework to design a tool that then uses the framework in some way. We're also looking at creating the ability to do more advanced searches on the framework, so things like semantic search capabilities, using things like vector embeddings. So if I'm sure most people are familiar with things like ChatGPT, a lot of these large language models use vector representations, vector databases under the hood. And what that means is, so if you look at this example, the word cat, the image cat, and the word kitten are closer together in vector space than, say, the word banana. And the word banana is closer to apple because they're both fruits. So what you start to do is you get kind of clusters in vector space of related topics. So using this, you can basically look for things based on concepts rather than necessarily matching keywords. So that helps us in the sense that keywords is great if people know what it is they're looking for, but if people are looking for something but they're not quite sure what it is, they know the concept but they're not quite sure what the words are, hopefully this kind of search would help them to find the statements more easily. So it's not going to be very heavy duty. We don't need to use there's lots of existing vector databases that you may or may not have heard of, Weaviate, Milvus, these kind of things, but we don't really need to use something so heavy duty. It could even just be using, say you're using Python, it could just be using a NumPy array or something to vectorize it. So it doesn't have to be anything sort of super complicated. But this enables this kind of semantic searching. So these projects are kind of pulling these things together. Can we improve the searching of these frameworks? Can we improve like the way we present them online? Can we have things like APIs that then allow you to work with them programmatically? So these are some of the kind of projects that we've got that are kind of like coming up, looking at maybe better ways of using the frameworks once we've developed them. So it's a range of skills from qualitative stuff that we've done through to more sort of data science stuff. We're developing these things. So the next steps, again, we've worked with some colleagues in Australia. We looked at our framework and their digital health in medicine framework for the Australian Medical Council. We talked a lot about kind of how we need to start joining these things up. So we've kind of put our money where our mouth is, and we started talking to people and making connections with people and sort of seeing where the overlaps are and how these things relate. So we've got a paper coming out hopefully soon about that, where we talk about the different frameworks and how they're kind of related. I'm also involved in a project with the Royal College of Surgeons, with someone doing their PhD at the University of Birmingham, so that's a surgeon. It's also related, they're also partnering with Cancer and Genomic Services, and they're basically making a training roadmap for robot-assisted surgery. So this is a project called RoboMap, and I might be going down to the Royal College of Surgeons in a few weeks to take part in one of their workshops, which is also going to use the nominal group technique. So I've been sort of helping with kind of how do they use that technique in their work. And finally, we've got the integration of findings from these different masters projects that we're running into a more up-to-date digital version of the framework. And then we're going to be looking at how we evaluate that. So once we've kind of got these projects, put them together, and we've got these kind of tools, we're going to look at running an evaluation where we get people to try and use the website and the tools and things and see how they found that using the to generate something. So we might look at how we're doing that. That's still open at the moment, but some initial ideas are things like maybe getting somebody to do a manual search and come up with maybe some ILOs for a fake course versus using these digital tools to do the same thing and seeing what they thought about that. You know, were they so part qualitative, quite quantitative, so see how quickly they were able to do it, see what their opinion of that was, and other suggestions. Quite a lot of talking this morning about the frameworks and things. So hopefully there's been something in that talk that's of interest to you, depending on what background you're coming from, whether it's some of the more technical stuff or whether it's more the methodological stuff, or maybe even just how we're using this and how it might be used. You can find the framework online. There's a website through HE that you can access the framework online. There's also a PDF version of the report with all the other bits and pieces in it. That's available through ResearchGate. So just a couple of acknowledgements there. So that's it from me. I don't know if anyone has any questions about any of that.
First of all, Alan, thank you. So this goes for people online as well, but does anybody in the room have any questions for Alan? Yes.
On the semantic search, just wondering, was that the vector embeddings? Are you looking at word embeddings or sentence embeddings or actual graph embeddings as well? I'm just curious what level that was on.
It's open at the moment, so we've just literally posted this as a framework, if you like, for a project. So depending on what the student's background is and what area they want to look at, it could be any of those things, or depends sometimes on their capability. With the health data science students, some of them have like quite a good software background, sometimes not. So it depends how far we can push them in that direction. But those are all good, things that we could explore.
Yeah.
We've got a question online from someone we might recognise, Ange Davies.
Oh, yeah.
We're going to try and put Ange on the speaker to see if this works.
We've also got.
Thanks. Can you hear me?
Yes, we can.
Oh, I'm getting. Oh, right. OK, I was getting feedback at the other end. Fantastic talk, Alan, and brilliant to see all this come together as such a body of work. Yeah, my question was resonating from something you said right at the beginning, actually, which was, you know, when we're expecting a nurse or a clinician to interact with these frameworks, it's about the usability. It's just got me thinking about what that looks like at their end. And, you know, when we're expecting them to deal with lots of different competency frameworks, which span their clinical work through to digital competencies and others, how do you think we can improve the usability of them from their perspective?
I think it's an important point. And I think the other thing is, if you've got a framework that you don't have to do, then we're really looking at people that might be sort of self-motivated to go and look at these things and identify gaps in their learning. So it's probably going to come from their managers or people like that that are going to use such things to see where the gaps are and maybe look at training. But I think definitely more of the co-design stuff is the way to go with that. So to work with the people that are going to use it to find the ways that they find most effective to get that into their very busy schedules and their workflows as complex as they are at the moment. So I think we definitely need more work to look at how we can make that more presentable, especially if it's not a framework that's enforced. So if they don't have to do it for professional regulations, then, you know, how do we encourage people to do that and access that? So we've got to find ways of making that more accessible, easier for them to do, and kind of almost and also to motivate them to do it as well, I think, in some cases. I don't have a tangible answer for how exactly we do that. There's lots of different, co-design techniques we could use, but again, it's kind of a bit open at the moment, I guess.
Thanks, Ange. Alex, I believe, has got a question.
Yeah, so it's very interesting, Alan, to hear the work you've done. And my question is, we are actually trying to do a similar thing, at least in much simpler forms, for a completely different area. And I was wondering whether your archetypes, how translatable you think they are to other domains that remain being digital and technically heavy, and also, of course, in the medical space. It sounds to me from the archetypes you define, and Ange knows a bit what I have in mind, so that they're pretty much translatable as archetypes, not perhaps necessarily the skills and the competences, but the archetypes, because that seems to be more based on how certain types of users relate to technology that has an impact on health. And therefore, where you have both type of users that produce the technology, which other users that may have a more sort of role as early adopters, while there is others that are sort of a more late followers. So there is something that has to do in the archetypes, the way you define it. I think is a lot more generic than for digital health. But I wonder whether you had some thoughts about that.
Yeah, I think that's a good point there. I think they are generic enough to use them across different types of things. Yeah, so if you decouple them from the actual capability statements, I think you could use them in lots of different places. And there's an advantage to that as well. If people are familiar with the same archetypes cropping up in different places, that is some familiarity for them, which kind of in some sense addresses also Angie's question in making it a bit more usable, because it's not a completely different thing each time they see one of these things. They start to see some kind of ubiquity. So it's, I recognize these archetypes from this framework, and now they're using the same one in this one. It kind of gives them a level, where these things become more familiar and therefore easier for them to use. So I think you could easily reuse them with completely different sets of competencies or capabilities. Yeah.
Thanks both. We've got another question online. So how can surgeons and medical professionals collaborate with the university to create AI or digital health projects to implement in an NHS environment?
Yeah, it's an interesting one. I mean, we're always looking for these collaborations. Really, I think it's just we often rely on kind of circumstances, like being in the right place at the right time. So attending certain talks, attending certain presentations. We recently had an FBMH showcase at the university. It's just an opportunity for us, even just internally, to see what other work people are doing. So I think often it's those kind of talks, network events, where we just find people, because there's so much going on. We're not always aware of what's happening. We also have organisations like the Pankhurst, for example, where we're at today. That obviously Alex runs, that people can contact, and different sort of hubs and areas that work on these things. That are probably a good initial port of call, at least, to see. I don't know if either of you two want to come back in, Andrew or Alex, on that as well.
Yeah, thanks a lot, Alan, because that's precisely what I wanted to say as well. And this was at the heart of why, when a few months ago John and I had a conversation about this series, we felt that it was hosting them in Pankhurst was a good environment, because it gives an exposure to all of you to what Pankhurst is, and we want the institute to be essentially an open institute where people could come with questions. So you have Karen there that I see here on the back of the screen, but Nicola Telfer would be normally the entry point for both themes and partnerships. And I want to emphasize that Pankhurst is not just the university. Pankhurst, when you go out of the room, Karen can point you to the board that we have, where there is all of our partners institutions, but Manchester Foundation Trust, Greater Manchester Combined Authority, and the NHS, Health Innovation Manchester, but also more broadly, Northern Care Alliance and the Christies. We're working very closely, and there is lots of projects. So if you don't know where to start, Pankhurst is kind of the entry door, and then we will help you, guide you to connect to the right people, which may end up being someone sitting in this room, but also maybe other people that perhaps today are not here, but are equally engaged and committed to Pankhurst.
Ange?
Yeah, thanks. It is a point to add to Alex's. I guess it's a plug, really. So we also have the International Collaborative for Translational Digital Health. So that's just worth mentioning. It's another. So myself and Dawn Dowding are co-directing that, and that's an opportunity to collaborate with actually collaborators even further afield. So that connects us with the University of Melbourne and Toronto, and sometimes we can bring in the expertise from those other institutions too. So yeah, happy to chat to anyone at any point if you've got ideas too.
I think we had a question in the room as well.
Yes, at the back.
Yeah, I can follow up on this question. As an example, so I'm a postdoc in AI NLP. Thanks for coming and follow this. Warren also in my group as a postdoc from Oliver. So our projects like by Goran, Magna, and Dixon, Will, it's about between university and NHS. So we have this project that is access the South hospital data, and we develop medication NLP tools and diagnostic tools. So this year actually is the third year of the project, so it's a delivery time actually. We have some well-trained model using embeddings, large language models, but without commercial software, for example, ChatGPT. Instead, we use open source framework, machine framework, and we train in anonymize the data. And then we aim to fine-tune it in the hospital data, so it can be adapted to this domain, to this country, and to this area. So the tools can do medication mining with around 90% accuracy at the moment. So if you drop a electronic health record, right, it can be a Nancy letter or it can be a history of many letters. And it can just tell you what this patient has been using in history by one click. We will support the clinician to understand a patient very easily. And that's one example. And we will also do more like diagnosis and relations to better to support the better understanding between patient and clinician. That's example.
Very interesting work, yeah.
Oh, I've just seen the time because we've got to end, but so we can carry on asking questions. But I'm just going to finish it for the team's call. So first of all, thank you very much everyone who's come here and online. Really appreciate your time. With Alex here on screen, it's definitely worth mentioning. Our next meeting is going to be May 21st, with Alex giving a talk for us. We've also got a meeting planned for July 10th. And Harriet Unsworth from Cancer Research UK is going to be coming down for a talk. So we've got some really interesting talks coming up. We're going to go and get a cup of tea and a donut. Thank you everyone who joined online. One thing I'll also say as well, if anybody's got any questions or they want to be put in touch with anybody, either from the talk or they want further information, my email's john.parkinson@manchester.ac.uk. Please get in touch with me and I can definitely point you in the right direction wherever you need to go. So thank you, everybody. We will see you next time. Take care now.